Hi, my name is Fu Shan. Thank you for having me on this platform to talk to you about growth assessment in the NICU. In today's talk, I will introduce an innovative growth reference tool developed using real-world longitudinal data from the Pediatrix clinical data warehouse. I have nothing to disclose. Here are the objectives of today's talk. After this talk, we will be able to describe the different types of growth reference tools for preterm infants and the limitations associated with intrauterine growth charts. We will also be able to describe the basic principles used in the development of postnatal growth charts for preterm infants. Finally, we will be able to demonstrate the descriptive, predictive, and prescriptive use of the postnatal growth charts for preterm infants. A simple way to describe growth is through the net effect of metabolic demand and supply. The metabolic demand includes metabolic needs at baseline and during acute or chronic states of illness. The supply depends on nutrition delivery and the digestive and absorptive abilities. Growth assessment is integral to our daily neonatal care in the NICU. We start the growth assessment before the infant is born to be prepared for how the infant may behave right after birth, to have realistic expectations, and to enable timely interventions in the delivery room. We perform anthropometric measurements at birth for short-term risk stratification. A common practice is to categorize infants as small, appropriate, or large for gestational age, depending on the birth measurement percentile. And this will help us initiate screening tools for risk assessment. During NICU hospitalization, most NICUs weigh infants daily and measure their length and head circumference at least once a week to monitor their growth. Many neonatal morbidities are associated with poor growth in the NICU. We also assess growth upon NICU discharge and compare it to the birth measurement for longer-term health risk assessment. In the NICU, weight gain are used as a surveillance tool for body homeostasis, including fluid balance and metabolic burdens, especially in the first week of life and during acute illness. Additionally, poor weight growth is associated with morbidities such as bronchopulmonary dysplasia, retinopathy of prematurity, and adverse neurodevelopmental outcomes. So one of the primary goals in the NICU is to ensure that infants are receiving adequate nutrition, support their growth, and to be able to guide our care towards optimal short and long-term outcomes. The goal of postnatal growth has been the subject of rigorous research. This is a statement published by the AAP in 1977. In the introduction, it says that the goal of feeding regimens for low birth weight infants is to achieve a prompt postnatal resumption of growth to a rate approximating intrauterine growth, as this is believed to provide the best possible conditions for subsequent normal development. It also described the need for increased caloric density in order to sustain satisfactory growth rate. So how do we determine or estimate the intrauterine growth rate? Estimated fetal weight has wide error margins and are therefore not used for estimating the rate of growth. A more widely acceptable method is to measure birth weight, length, and head circumference and plot these measurements against their birth gestation. This pattern is generally considered intrauterine growth, as birth measurements represent the end results of fetal growth. A bunch of birth measurement data can be grouped together by gestational age and used to calculate the median value from each group. The values over a range of gestational ages are then connected and smoothed to form a curve. This curve represents the estimated intrauterine growth pattern. We can then calculate the slope of the curve to derive the median growth rate. How we smooth the curve may affect how the estimated growth rate appears. What I just described is the basic concept of how intrauterine growth charts are created. These growth charts are cross-sectional because each infant only contributes one data point. In modern days, intrauterine growth charts are developed in a more sophisticated way. You may have heard of the LMS table in many growth charts that we routinely use in clinical practice. The LMS values are the values that transform the birth weight distribution for each indicated gestational age into a normal distribution. Modeling the LMS values together over a range of gestational age allow us to obtain the percentile curves and calculate the z-scores. This type of growth charts allow us to compare preterm infants to their fetal counterpart at the time of birth for each indicated postmenstrual day. Different from intrauterine growth charts, postnatal growth charts, on the other hand, take a cohort of infants, follow their growth over time, and we use statistical methods to describe their growth pattern and the rate of growth in a mathematical model. This type of growth charts allow us to compare infants to their peers. Before we move on, let's review some of the well-known growth charts that have received great attention in the care of preterm infants. The chart on the left side was published in 1948. This was the first chart for preterm infants that I could find in the literature, although the paper mentioned two other charts that it compared itself to. One was also from New York, and the other one was from Boston. This was a weight category-based postnatal chart covering birth weight between 1,000 and 2,500 grams. In 1963, the Lubchenco charts were published. These were a set of sex-specific intrauterine growth charts covering birth gestations between 24 and 42 weeks. Dr. Lubchenco was the first to introduce the terms SGA, AGA, and LGA for risk stratification. After the Lubchenco charts, at least two additional intrauterine growth charts were published in North America. Fast forward to 1999, Dr. Aaron Kranz developed another set of postnatal growth charts based on birth weight categories. The cohort contained 1,660 infants from the NICHD Neonatal Research Network, born with a birth weight between 500 and 1,500 grams. In this project, they split postnatal growth into three phases and pre-specified the formula for each of the three phases for trajectory modeling. Unfortunately, this set of growth charts did not take birth gestation into consideration, and so there were no percentile lines for each gestational age group. In 2003, Dr. Fenton published the first version of the Fenton growth charts for weight, length, and head circumference. The charts were not sex-specific, and these curves were connected to the CDC growth charts. The gap was manually smoothed. In 2010, Dr. Olson and her research team used Pediatrix birth measurement data from 1998 to 2006 to create the Olson charts. The charts were created based on infants admitted to the NICU. The Olson charts are sex-specific. In 2013, Dr. Fenton revised the Fenton charts by conducting a meta-analysis of 6 studies. The weight curves were based on all 6 studies, including 25% of the data points from the Olson study. The length and head circumference were based on 2 of the 6 studies. The resultant curves were connected to the WHO child growth standards, starting at 36 weeks postmenstrual age, to extend the charts to 50 weeks. The curves were smoothed using cubic spline, which means that the growth rate would appear smooth too. Easy for the eyes, but not really physiological. In this paper, published in 2018, two methods were used to estimate intrauterine growth rates. The average and the exponential model were compared for various intervals between two data points. As long as the interval is not too wide, the two formulas gave similar results. Using these two formulas, median growth velocity are calculated using the 50th percentile curves from both 2010 Olsen and the 2013 Fenton charts, among others. As shown here, the median growth velocity was somewhere between 15 and 20 grams per kilo per day before reaching 34 weeks postmenstrual age. Looking at this landmark paper published by Dr. Aaron Kranz in 2006, using a subset of the NICHD Neonatal Research Network cohort, the findings indicated that increasing the growth rate to a range corresponding to intrauterine growth rates of 15 to 20 grams per kilo per day between birth and reaching 2,000 grams was associated with improved neurodevelopmental outcomes, even after adjusting for demographic factors and neonatal morbidities. For length, the median intrauterine growth velocity is around 1.2 to 1.5 centimeters per week before 34 weeks postmenstrual age. For head circumference, the median growth velocity is around 0.8 to 1.0 centimeters per week. A general theme here is that the intrauterine growth rates of all parameters begin to decrease after the fetuses reach 34 weeks postmenstrual age. Also, these values represent median growth velocities calculated from the 50th percentile curves. Those fetuses tracking lower or higher percentiles may have different rates of growth. The intrauterine growth charts are helpful for calculating and estimating fetal growth rates, but they have their own limitations. We will discuss some of these limitations here. The first limitation is that birth measurements are probably the least reliable measurements throughout the entire NICU stay. This could be due to the use of respiratory support devices and wires. Also, C-sections versus vaginal delivery can affect head circumference measurement significantly. Moreover, for each gestational age, there is a mix of spontaneous and medical deliveries. Based on obstetric practice guidelines, the proportion of each type of delivery may vary for each gestational age group. Some antenatal or maternal morbidities that may alter fetal growth are also indications for medical delivery. Additionally, the distribution of birth measurements for each gestational age group may depend on the selection criteria. For example, in the 2010 Olsen charts, only 2/3 of the input data were included in the final growth charts. Looking from a longitudinal standpoint, connecting the dots from cross-sectional data and use them to assess longitudinal growth velocity might be problematic because the composition is different for each gestational age group. So we're connecting apples to oranges. The third limitation concerns the environment. While the intrauterine environment is confined, the crib or the isolates are not. The differences in growth between preterm infants and the near-term fetuses may give a false impression of what we thought of as catch-up growth. Also, there is biological limitations to the placental supply of nutrients, while we have plenty amount of fortified milk in the NICU. Finally, the choice of smoother in developing intrauterine growth charts can affect the growth velocity calculation. For example, a cubic spline smoother will produce a smooth curve for the growth rate as well. Depending on how smooth you like the final curves to be, some connected lines that are going downwards may be smoothed out. Of course, a reduction in fetal growth is impossible without significant complications. The downward trend in raw data simply reflects the differences in the populations included in each cross-section. These are some of the median growth curves for each of the gestational age group between 23 and 28 weeks. Postnatal weight gain approximately parallels intrauterine growth charts for a narrow window between 30 and 34 weeks. Yet, they followed a similar postnatal growth pattern when you compare them to one another. Similarly, length growth followed a pattern that is different from intrauterine growth pattern. Whereas in intrauterine growth, the curve follows a convex shape, postnatal growth follows a more or less a concave shape. For head circumference growth, there is minimal growth in the first week of life, followed by a rate that is higher than the intrauterine growth rate. So intrauterine growth and postnatal growth are different. Even though the intrauterine growth chart has its role in promoting neonatal nutrition and the growth of our most vulnerable population, its use could still be challenging. For one, when using the intrauterine growth charts, manually calculating growth velocity is necessary, and it is recommended that growth velocity should not be assessed with an interval shorter than every 5 to 7 days. In other words, the assessment is retrospective and spans a long period of time. They are not real time. Earlier, I've shown you two postnatal growth charts published by Dr. Densis and Dr. Ehrenkrantz. Postnatal growth charts are the alternative option. Do they provide a better way to monitor growth of preterm infants in the NICU? First of all, these two published postnatal growth models only include weight charts, and they were solely based on weight categories, without accounting for birth gestation. However, we know that a 1 kilo infant born at 26 weeks differs in their growth potential from a 1 kilo baby born at 32 weeks. More importantly, postnatal growth charts reflect the growth trend based on nutrition practices at the time, and these charts may not capture a rate that approximates fetal growth rate. So, in addition to the charts not being gestational age based and lacking percentile lines, what concerns neonatal providers most in using these postnatal growth charts is probably the representative of the growth charts in terms of growth goals. We may be worried about the possibility that these postnatal growth charts would be too optimistic about postnatal growth, resulting in inadequate nutrition and suboptimal growth. However, we have not reached consensus on how to use the intrauterine growth charts to assess growth faltering either. The use of the z-score at 36 weeks postmenstrual age and the use of the delta z-score of -0.8 may not be appropriate. Growth velocity is probably still the gold standard. Here are some facts to consider when developing postnatal growth charts. One advantage is that the postnatal growth charts are based on a pre-selected cohort, and therefore the composition of the cohort does not change over time. Also, with the advancement of computer technology, more sophisticated algorithms that can account for variations in birth size and the growth rates of each individual infant can now be used. On the other hand, postnatal growth charts based on historical longitudinal growth of preterm infants do still reflect growth and nutrition practices at that time. By itself, this attribute is not a pro or a con. It just all depends on the cohort we pick to model postnatal growth, whether we think that the cohort represents modern nutrition practice or not. In contrast to intrauterine growth charts, where one infant contributes one data point, in postnatal growth charts, each infant contributes a different number of data points. So there could potentially be issues associated with missing values due to transfer, death, or home discharge at various gestational ages. So, are we ready for another attempt at postnatal growth charts? Over the past decade, there have been significant improvement in nutrition practices. Is postnatal growth rate much closer to the intrauterine growth rate now? Also, do we have enough data points on postnatal growth to make the charts generalizable? Do we have enough computing power to be able to take advantage of more sophisticated algorithms to address the issues we just discussed earlier? Thanks to Dr. Mitch Goldstein at Loma Linda University, I was able to be connected to Dr. Reese Clark in 2021 and had a wonderful opportunity to collaborate with Pediatrix and have access to a huge amount of valuable data from the Pediatrix data warehouse for me to use to model postnatal growth. In this project, we aim to understand how we are growing our preemies in the modern days and to see if we could convert postnatal growth models into clinically useful growth reference tools. With clinical application in mind, we wanted the postnatal growth models to be as inclusive as possible and be representative of the entire population. From a technical standpoint, we did not want to set any restriction on growth trajectory path. Finally, our goal was to integrate these growth charts into clinical practice, so we hope that the charts would simplify the growth assessment workflow in the NICU. To elaborate further, the only exclusion criteria would be when there is no data. In utero or ex-utero exposure or congenital anomalies would not be used to exclude infants. Additionally, we acknowledge that even if growth follows a simple mathematical formula, we do not want to pre-specify it, and we should not do it. And this includes not setting constraints for the initial weight loss phase. Finally, we wanted to develop a tool that is both intuitive and visual. And we understand that all scales have their own inherent error range and that all measurements have their own intrinsic error margin, which is part of the real-world experience. We hope that with the growth trajectory models, we will be able to visualize that. Also, if the postnatal growth trajectory represents an expected course of growth, then that means that growth becomes predictable. And so the charts may be used in a predictive manner and also be used in a prescriptive fashion. We'll return to these concepts later. In this project, we used data from Pediatrix to identify clinical data warehouse. This data warehouse hosts data from about 20% of infants born in the United States who were admitted to the NICU. These are real-world data from Pediatrix NICUs that use the Baby Steps electronic health records. We included infants born between 2010 and 2020. In the first phase of development, we focused on small babies, including those born between 22 weeks 4 days and 30 weeks 3 days. In the second phase, we expanded and included up to 34 weeks 3 days. All infants included in the study were admitted to one of the Pediatrix NICUs within 7 days of life. The only exclusion criteria were the lack of sex assignment or the lack of any anthropometric data. Again, we did not exclude infants based on mortality, morbidity, or antenatal or postnatal exposure. We understood that there is no one-size-fits-all way to describe postnatal growth, so we grouped infants for model development using sex and rounded gestational age. The algorithm we used for growth modeling was called Generalized Additive Mixed Modeling, or GAME. The term additive indicates that the trajectory is modeled in a piecewise fashion, without any pre-specified trajectory path assumption. The term mixed indicates that we took variations in birth size and growth rates of each individual infant into consideration when developing the model. In other words, measurements from one infant are considered together instead of treating all data points as independent values from one another. GAMM requires a normal distribution assumption for the residuals. Therefore, in the model, the z-scores and the percentiles calculation is based on the mean and the standard deviation instead of the LMS table. Finally, we modeled growth against day of life, and we censored data at an age that corresponds to 44 weeks postmenstrual age. In phase 1 development, we included infants born between 22 weeks 4 days and 30 weeks 3 days. We identified over 89,000 infants from the database, over 5.4 million weight data points, over 750,000 length data points, and over 1.3 million head circumference data points. In phase 2, over 225,000 infants born between 30 weeks 4 days and 34 weeks 3 days were included. There were approximately 5.4 million weight data points, around 890 length data points, and over 1.3 head circumference data points. Here is an example of the postnatal growth charts. This is for the 25-week female group. The percentile lines presented here go from the 3rd, 10th, 25th, 50th, 75th, 90th, 97th percentile from bottom to top. Any percentile line can be calculated using the mean and the standard deviation for each day of life. As the models were developed against the day of life, in this graph we show two x-axes. The top one is for chronological age, and it's the one that was used for model development. And the bottom is the postmenstrual age. As you can see here, small babies grow slower and large infants grow faster. This is the length models for the 25-week female group, with two x-axes showing postnatal age on top and postmenstrual age at the bottom. And this is the head circumference chart for the same 25-week female group. Here I'm showing you comparisons between postnatal growth trajectory and the 2013 Fenton intrauterine growth charts. As you can see here, the median weight gain velocity, or the slope, between 28 and 34 weeks may be in approximate parallel to each other. The other percentile curves between two charts were not. In postnatal growth, lighter infants grow slower and heavier infants grow faster, but this is not always the case in intrauterine growth charts. For length growth, intrauterine growth curves follow a convex shape, whereas postnatal growth follows a concave shape. For head circumference growth, there is minimal growth in the first week of life, followed by a growth velocity that is similar or even faster than the intrauterine growth rate, depending on percentile curves. These differences between intrauterine and postnatal growth patterns look familiar. We have seen them in an earlier slide. The median weight growth trajectories for each group between 23 and 30 weeks were plotted together against the 2013 Fenton growth chart for comparison. It is reassuring to see that the estimated birth weight for each group is right on the 50th percentile line of the Fenton curves, as it should be. The models captured the initial weight loss phase. In all models, the nadir of the estimated weight occurs on day of life 4. These models all start on day of life 0, so this would be the 5th day. The estimated birth weight was regained between day of life 8 and 10, depending on the gestational age group. Estimated weight velocity in grams per kilo per day can be calculated by taking the difference in estimated weight between the 2 consecutive days, then divided by the estimated weight for the first day. We can then plot the mean weight gain velocity in grams per kilo per day. And we see here that after the initial weight loss and returning to birth weight, the weight gain velocity in grams per kilo per day followed a sinuous horizontal line between 15 and 20 grams per kilo per day until around 34 weeks postmenstrual age. We didn't see a difference between males and females. This is similar to what was calculated using the Olsen and the Fenton chart between 34 weeks. We named this phase weight acceleration phase because the weight gain velocity is a function of the current weight. Interestingly, in the later gestational age groups, if the initial weight loss phase ends after 34 weeks postmenstrual age, the weight acceleration phase seems to be skipped. The weight velocity curve joins the third phase. So how is the third phase defined? If we calculate the weight gain velocity in grams per day from all gestational age groups and we plotted them together, the curves appear more or less a sinuous horizontal line ranging between 25 to 35 grams per day, a little higher in males than in females. And this is the third phase. We name this phase the stable weight gain phase because the estimated weight gain velocity is not a function of current weight anymore, but a relatively constant value. In later gestational age groups, after the initial weight loss phase ends, weight gain appears to go directly into the stable weight gain phase. Now, we take all the percentile curves from 0.1 to 99.9 and we calculate the mean weight gain velocity in grams per kilo per day in the weight acceleration phase and plot them against the percentile. We see that most growth velocity falls between 15 and 20 grams per kilo per day, except for really low and really high percentiles. This range of growth velocity is the expected rate of intrauterine growth. Similarly, when we plot the mean weight gain velocity in the stable weight gain phase against the percentile between 0.1 and 99.9, we found that most of the weight gain velocity fall between 20 and 40 grams per day, with the majority falling between 25 and 35 grams per day. So, does postnatal growth follow a distinct pattern from intrauterine growth? I think the answer is yes. Does postnatal growth meet the goal of following a rate approximating intrauterine growth? I think the answer is also yes. So we put these postnatal growth models together and we created a set of growth charts. We call them postnatal growth charts for preterm infants. And we feel that this set of postnatal growth charts may be a clinically useful tool for growth assessment in the NICU. In the era of data science and data analytics, we talk about 3 types of analytics. They are descriptive, predictive, and prescriptive analytics. In descriptive analytics, the findings describe what has happened in the past. We learn from past experience. This is what we're doing now. We summarize growth velocity by calculating average growth over the past week or 2 weeks. The results can be used for diagnostic purposes, for example, to determine if growth is faltering. At the next level, data analytics can be predictive, where we use the results to forecast future outcomes. At an even higher level, data analytics can be prescriptive, which means that we not only forecast future outcomes, but also provide actionable recommendations to alter the course leading to an unfavorable outcome before it even happens. The postnatal growth charts for preterm infants result from growth data analytics and can be used to describe and to predict growth. I think they even provide near real-time growth assessment and actionable recommendations based on the predictions. Let's take a look at how we may achieve these goals. For descriptive use, we can plot the infant's weight on the growth charts, for example. Here, I'm showing the postnatal growth of a female infant born at 25 weeks, 0 days. The arrows point to specific weights at different days of life, and the corresponding z-scores and the percentiles are calculated accordingly. Please note that z-scores are full changes relative to the standard deviation, and percentiles are the cumulative probability. The percentile ranges from 0 to 100, whereas the z-score ranges from -infinity to +infinity. Both are continuous in nature, and they have a one-to-one relationship. Because we know the trajectory of female infants born at 25 weeks, we can draw any trajectory percentile curve based on the mean and the standard deviation for each day of life. We could find a regression trajectory curve that best summarizes the growth. In this case, it is the trajectory at 85.8 if we use least mean squared error. The trajectory percentile is useful because it allows us to visually inspect growth trajectory and can detect measurement errors visually. For the trajectory percentile of 85.8, the corresponding growth rate is 15.8 grams per kilo per day in the weight acceleration phase and 34 grams per day in the stable weight gain phase. Now we can take a closer look at this infant's growth at around 2 to 3 weeks of age. You can tell that all weight data points are below the trajectory percentile curve. If we use the first 12 days of data to find the trajectory percentile, the representative percentile is 82.1. We found that all the subsequent data points went below the percentile line. And I use past tense because we did not use the postnatal growth charts for preterm infants to guide nutrition at that time. The overall growth in the next 2 weeks was only 72% of the expected growth, corresponding to an average of 11.4 grams per kilo per day. We probably could have done something sooner. However, it takes a longer period of time to identify infants with growth faltering when we use the intrauterine growth charts and had to calculate the growth velocity manually. Now let's take a look at the predictive use of the growth charts. Using this same case again, the trajectory percentile was 85.8, with a corresponding growth rate of 15.8 grams per kilo per day in the weight acceleration phase and 34 grams per day in the stable weight gain phase. We have already looked at the birth percentile. For this infant, it was 84.8. And so if we just use the birth percentile, we could already predict what growth would be like for this infant. The growth rate would be 15.8 grams per kilo per day in the weight acceleration phase and about 34 in the stable weight gain phase, similar to the final trajectory. shows. So this is like entering destination in your map app to obtain the ETA, right? You know when you'll get to the destination before even starting driving the car. For prescriptive use, in this case, as we already mentioned earlier, we could have started working on optimizing nutrition as soon as we started seeing weight measurements consistently below the trajectory curves, instead of waiting for 2 weeks to go by before advancing calories. Another prescriptive use of postnatal growth charts is illustrated here. So this is a 31-week male infant who did well until 22 days of life when he developed necrotizing enterocolitis. As you can see here, 2 to 3 days before NEC, he started having issues keeping up with his weight gain, even though there were no changes in his clinical status and his nutrient delivery. So any unexpected deviation from the growth trajectory could lead to actionable recommendations to look further into why growth is not following the trajectory. Here is another example of the prescriptive use of postnatal growth charts. So this is a 28-week male infant who did well until 13 days of life when he developed surgical necrotizing enterocolitis. As you can see here, weight started to fluctuate after NEC developed. So the overall trajectory percentile wasn't very useful. So if we use the weight data points before NEC to calculate the trajectory percentile, we can see that a lot of the fluctuated weight are fluid weights. And we can also set expectations for how growth should proceed after the infant recovers from the acute illness. And this is another example of the prescriptive use of the postnatal growth charts. In addition to its clinical use, we have also used the postnatal growth charts for research purposes. And these are two recent publications in Journal of Perinatology. The top one is the one that we used the postnatal growth charts for preterm infants to assess the impact of exclusive human milk diets on short-term growth. And the second one is another study that we did to assess the role of antenatal corticosteroids exposure on postnatal growth. Before I end this talk, allow me to thank Dr. Clark and Dr. Ye of the Children's Mercy Research Institute for their collaboration and mentorship. And I also would like to thank Dr. Mitch Goldstein again for connecting me with Dr. Clark. We have created a web app to host the postnatal growth charts for preterm infants for public access. You can simply type in NICU growth.app in your browser to access the web app. There is a sign up button for you to take you to the sign up page to create an account. Or you can use test, T-E-S-T, all lowercase for user ID and password to play around. And before I end this talk, I would like to show you this video for a demo on how to use it. We also created a YouTube channel to host 5 videos to show you how to use the web app's different functions. The channel name is NICU Growth_app. Thank you so much for joining this presentation. If you would like to read more about our work, you can use the QR code on the right side to access our paper. It's open access, so anyone should have access to it. Here are my contact information. You can reach out to me via email. Thank you so much. Again, I'd be happy to take any questions.